Okay, now in this video we are going to read about acute pancreatitis from Nelson's part 2, page number 2426. Let's start. Acute pancreatitis is the most common pancreatic disorder in children. 50 or more cases are usually seen in the major pediatric centers per year. In children, blunt abdominal injuries, multisystem disease such as the hemolytic uremic syndrome, and inflammatory bowel disease, biliary stones, or microlithiasis and drug toxicity are the most common etiologies. So we have to remember the etiologies. Fine. Let's read them once again. First one is blunt abdominal injuries. So you have to remember, if a child is presenting recurrently with pancreatitis in every few years or every few months, blunt abdominal injury can be one of the cause. Multisystem disease such as hemolytic uremic syndrome (HUS) or inflammatory bowel disease (IBD) and biliary stones or microlithiasis. Fine. Also, drug toxicity can also be one of the cause. Are the most common etiologies. Although many drugs and toxins can induce acute pancreatitis in susceptible persons, in children, valproic acid. Now we are talking about drugs. Which drugs are mainly associated here? First one is valproic acid and L-asparaginase, 6-mercaptopurine and azathioprine. These are the most common causes of drug-induced pancreatitis. Fine, let's revise it again. It's very important to remember the causes of acute pancreatitis in children. Blunt abdominal injury, hemolytic uremic syndrome, IBD and biliary stones, and drug toxicity. Mainly which drugs? Valproic acid, L-asparaginase, 6-mercaptopurine and azathioprine are the most common causes of drug-induced pancreatitis. Alcohol should be considered in adolescent ages. Other cases follow organ transplantation or are caused by infections, metabolic disorders or mutations in susceptibility genes. Only 10 to 20% of the cases are idiopathic. Fine. So these are the other causes of acute pancreatitis. It can be organ transplantation or caused by infection or any metabolic disorder or any mutation in the genes. And there is also idiopathic one, which is 10 to 20%. After an initial insult such as the ductal disruption or obstruction, there is premature activation of trypsinogen to trypsin. Now we are reading about the pathophysiology, what is happening. So there is a ductal disruption or obstruction. Ductal disruption or obstruction is happening. There is premature activation of due to this ductal obstruction, there is premature activation of trypsinogen to trypsin within the SNR cells. Trypsin then activates other pancreatic proenzymes. Fine, trypsin got activated, then trypsin is activating the other pancreatic proenzymes, leading to autodigestion. We know this pathophysiology, right? Due to obstruction, trypsin is activated, trypsin then activates other proenzymes, which leads to, the main thing is autodigestion. Further enzyme activation and release of active proteases. So other proteases are also released and other enzymes are also activated. Lysosomal hydrolases co-localize with pancreatic proenzymes within the SNR cells. So lysosomal hydrolases also co-localize. They are also present with this pancreatic proenzyme in the SNR cells. And pancreatitis, similar in concept of cholestasis, pancreatitis. Similar in concept to cholestasis, with continued synthesis of the enzyme occurs. Lecithin is activated by phospholipase A2 into the toxic lysolecithin. Phospholipase is unstable and can be activated by minute quantities of trypsin. After the insult, cytokines and other pro-inflammatory mediators are released. So some things which happened similar in cholestasis, there is also pancreatitis. So due to this, the pancreatic enzymes are being collected or stored at one place, and due to this There is continued synthesis which is ongoing. So lecithin is activated by phospholipase A2 into lysolecithin. This phospholipase is unstable and can be activated by minute quantities of trypsin also. We saw, right? Trypsin was activated, and phospholipase then can also be activated by trypsin. After the insult, cytokines and the other pro-inflammatory mediators are released. The healthy pancreas is protected from autodigestion by pancreatic proteases that are synthesized as inactive proenzymes. The healthy pancreas is protected from autodigestion by pancreatic proteases. How is it protected from autodigestion? By pancreatic proteases that are synthesized as inactive proenzymes. Digestive enzymes that are segregated into secretory granules at pH 6.2 by low calcium concentration, which minimizes the trypsin activity. The presence of protease inhibitors both in the cytoplasm and zymogen granules, and enzymes that are secreted directly into the ducts. Histopathologically, interstitial edema appears early. Later, as the episode of the pancreatitis progresses, localized and confluent necrosis and blood vessel disruption leading to hemorrhage and an inflammatory response in the peritoneum can develop. The diagnosis of pancreatitis in children is made when 2 of the 3 of the following are present. When we make diagnosis, when there is abdominal pain, serum amylase or lipase activity at least 3 times greater than the upper limit of normal, and imaging findings characteristic of or compatible with the acute pancreatitis. Fine, we need 2 of the 3 things. So what must be present? At least if there might be abdominal pain or serum amylase or lipase activity at least 3 times greater than, how much? 3 times of the upper limit of normal, or imaging findings. So out of these 3, any 2 must be present to diagnose acute pancreatitis. Now the clinical manifestation. The severity of the acute pancreatitis in children has been defined by a consensus committee. Mild acute pancreatitis. Acute pancreatitis that is not associated with the organ failure, local or the systemic complications, and usually resolve within the first week after presentation. This is the most common form of pediatric acute pancreatitis. What is the most common form? Which is acute pancreatitis, which is mild one. Fine, mild one which is not associated with any organ failure or local or systemic complications, and usually resolve within first week after presentation. It usually resolves within first week after presentation. Fine, and that one is the most common form of pediatric acute pancreatitis. The patient with the mild acute pancreatitis has moderate to severe abdominal pain. Fine, there will be moderate to severe abdominal pain. Mild acute pancreatitis. Fine, these are the symptoms. Persistent vomiting, possibly fever. The pain in the epigastric or in the either upper quadrant, and the pain in the epigastry or in either upper quadrant and steady, often resulting in the child's assuming an antalgic position with the hips and knees flexed. There is something called antalgic position in which the hips and the knees are flexed, sitting upright or lying on the side. The child is uncomfortable, irritable, and appears acutely ill. How is the child? It's uncomfortable, irritable, and appears acutely ill. The abdomen may be distended and tender, and mass may be palpable. Abdomen may be distended, it may be tender, and then a mass may be palpable. The pain can increase in intensity for 24 to 48 hours, during which the vomiting may increase and the patient can require hospitalization for fluid and electrolyte therapy and analgesia. There is no other organ failure, and imaging does not demonstrate peri or pancreatic necrosis. The prognosis for complete recovery in acute and complicated case after 4 to 7 days is excellent. Fine. Now coming to the second type, that is the moderate severe acute pancreatitis. Acute pancreatitis with either transient organ failure / dysfunction lasting for less than 48 hours or development of local or systemic complication. There is some development of complication such as exacerbation of previously diagnosed comorbid disease such as kidney or lung disease. There is any exacerbation, and imaging reveals sterile pancreatic necrosis. The prognosis for these patients is also excellent, but recovery may be prolonged. So prognosis of acute pancreatitis is actually really good. Now, in severe acute pancreatitis with development of other organ dysfunction. Severe, when we are calling it severe, when there is development of any other organ dysfunction, lung or the cardiac or the renal, that persists longer than 48 hours. Persistent organ failure may be single or multiple. Severe acute pancreatitis is uncommon in children. Fine, this is very uncommon in children. In this life-threatening condition, the patient is acutely ill with severe nausea, vomiting and abdomen pain. It is a life-threatening condition, this severe acute pancreatitis, and the patient is acutely ill with severe nausea, vomiting and abdominal pain. Fine, so what is happening here? It is a life-threatening condition. The patient is acutely ill with severe nausea, vomiting and abdominal pain. Shock, high fever, jaundice, ascites, hypocalcemia and pleural effusions can occur. These are kind of like the complications of it. Like shock can occur, high fever, jaundice, ascites, hypocalcemia and pleural effusion. A bluish discoloration may be seen around the umbilicus. Okay, that is Cullen sign, or in the flanks, that is Grey Turner sign. These two signs may be seen, and these two signs are actually important. A bluish discoloration may be seen around the umbilicus, that is called as the Cullen sign, or if it is seen in the flanks, that is called as the Grey Turner sign. The pancreas is necrotic and can be transformed into an inflammatory hemorrhagic mass. Pancreas is, in severe cases, it is necrotic and it can transform into an inflammatory hemorrhagic mass. The mortality rate, which is approximately 20%, the mortality rate is high in severe acute pancreatitis. Just 20% is related to the systemic inflammatory response syndrome with the multiple organ dysfunction. It is related to what? That is something called as the SIRS response syndrome, that is systemic inflammatory response syndrome with multiple organ dysfunction. Shock, renal failure and acute respiratory distress syndrome, disseminated intravascular coagulation, gastrointestinal bleeding and systemic or intra-abdominal infection. The percentage of necrosis seen on the CT and the failure of the pancreatic tissue to enhance on the CT suggesting necrosis predicts the severity of the disease. So what is predicting the severity of disease? The percentage of necrosis seen on the CT and failure of pancreatic tissue to enhance on the CT. Fine, percentage of necrosis and failure of pancreatic tissue to enhance, which suggests necrosis actually. Now coming to the diagnosis, acute pancreatitis is usually diagnosed by the measurement of serum lipase and amylase activity. Serum lipase is considered the test of choice for acute pancreatitis because it is more specific than amylase for acute inflammation. What is more specific is serum lipase is more specific than amylase for acute inflammatory pancreatic disease, and should be determined when the pancreatitis is suspected. Fine. The serum lipase rises by 4 to 8 hours, peaks at 24 to 48 hours and remains elevated for 8 to 14 days longer than the serum amylase. So serum lipase, this remains elevated for 8 to 14 days longer than the serum amylase. Okay. Serum lipase greater than 7 times the upper limit of the normal obtained within 24 hours of the presentation may predict a severe course. Okay. If the serum lipase is greater than 7 times the upper limit of normal within 24 hours of the presentation, it may predict a severe course. Serum lipase can be elevated in the non-pancreatic diseases. Serum lipase can be elevated in the non-pancreatic diseases. Serum lipase can be elevated in non-pancreatic diseases. The serum amylase levels is typically elevated for up to 4 days. A variety of other conditions can also cause hyperamylasemia without pancreatitis. Elevation of the salivary amylase can mislead the clinician to diagnose pancreatitis in a child with abdominal pain. The laboratory can separate amylase isoenzyme into pancreatic and salivary fractions. Initially, serum amylase levels are normal in 10 to 15% of the patients. Other laboratory abnormalities that may also be present in the acute pancreatitis include, these are the other abnormalities which may also be seen, like hemoconcentration, coagulopathy, leukocytosis, hyperglycemia, glucosuria, hypocalcemia, elevated gamma glutamyl transpeptidase and hyperbilirubinemia. Fine. These are the other lab abnormalities. So there is like coagulopathy is commonly seen, leukocytosis is seen, hyperglycemia is seen, glucoseuria, hypocalcemia, and elevated gamma glutamyl transpeptidase, that is GGT. There is elevated GGT which is also normally seen, and hyperbilirubinemia also. This is also normally seen. Okay. X-ray of the chest and abdomen might demonstrate non-specific findings such as you can see atelectasis, you can see basilar infiltrates, you can see elevation of the hemidiaphragm, left-sided pleural effusion. There is left-sided pleural effusion. There is pericardial effusion. There is pulmonary edema. Fine. These are the things which will be seen on X-ray, such as what we saw was atelectasis, there can be basilar infiltrates, there can be elevation of the hemidiaphragm, left-sided pleural effusion can also be seen, there can be pericardial effusion also, and pulmonary edema also. Abdominal X-ray might demonstrate a sentinel loop dilation of the transverse colon. Sentinel loop, that is dilation of the transverse colon, that is called as the cutoff sign, colon cutoff sign. Ileus pancreatic calcification if recurrent. There can be pancreatic calcification if recurrent. Blurring of the left psoas margin, a pseudocyst. These are the things which can be seen on the X-ray. There can be blurring of the left psoas margin, a pseudocyst may be seen, a diffuse abdominal haziness or ascites, and peripancreatic extraluminal gas bubbles can also be seen. CT has a major role in the diagnosis and follow-up of children with pancreatitis. CT has a major role. Fine. In what? In the diagnosis and follow-up of children with pancreatitis. Findings can include what can be seen on the CT. Pancreatic enlargement can be seen. Hypoechoic sonolucent edematous pancreas. Hypoechoic sonolucent edematous pancreas can be seen. There can be pancreatic masses, fluid collection, and abscesses. Okay, fluid collection and abscesses. Normal imaging studies at the time of the diagnosis are not uncommon. In adults, CT findings are the basis of widely accepted prognostic system, which is written in this table. Are the basis of ultrasonography is more sensitive than CT for the diagnosis of biliary stones. If you are suspecting any biliary stones, so USG is more sensitive than the CT for diagnosis of any biliary stones. Magnetic resonance cholangiopancreaticography, that is MRCP, and endoscopic retrograde cholangiopancreaticography, that is ERCP, are essential in the investigation of recurrent pancreatitis, non-resolving pancreatitis, and disease associated with the gallbladder pathology. Fine. So this MRCP and ERCP, they are the essential investigations of recurrent pancreatitis. If there is recurrent pancreatitis, then we should do these investigations, ERCP and MRCP, and non-resolving pancreatitis and disease associated with the gallbladder pathology. Endoscopic ultrasonography also helps visualize the pancreatico-biliary system. Complications of the acute pancreatitis are noted in the table that we'll read further. This is the table. Etiology of the acute and recurrent pancreatitis in children. Let's look at the etiology. It's a big table. We'll see. Let's start. First, we are going to start with the drugs and toxins. Okay. First is acetaminophen, that is paracetamol overdose, alcohol, anabolic, androgenic steroids. There can be L-asparaginase, azathioprine. These were all from A. These 5. Let's read them again. Acetaminophen overdose, alcohol, anabolic, androgenic steroids, L-asparaginase, and azathioprine. Now from C, we have cannabis, carbamazepine. Carbamazepine is a hyperthyroid drug, and cimetidine, and cisplatin, corticosteroids, and cytosine arabinoside. These 6. These are again drugs and toxins causing acute and recurrent pancreatitis. Now from D we have only 2, that is dapsone and danosine. Then from E we have enalapril, erythromycin, estrogen. We have 3 from E. Then from F we have furosemide. From G we have glucagon-like peptide 1 agents, interferon and isoniazide, lamivudine and lisinopril, 6-mercaptopurine, methyl dopa, mesalamine and metronidazole. These are the M drugs. Now coming to the organophosphate and pentamidine and procainamide. Retroviral drugs also can cause, like the DDC, dideoxycytidine, DDI, dideoxyinosine and tenofovir, rifampin, sulfonamides and sulindac. Sulfonamides like mesalamine, 5-aminosalicylates, sulfasalazine, trimethoprim sulfamethoxazole. Now from T, tetracycline and thiazides, valproic acid, venom, vincristine. There are 4 from V, valproic acid, venom of spider, scorpion and I don't know what to say, gila or gila, monster lizard, vincristine and volatile hydrocarbons. Now from the genetic, these were all the drugs which were causing acute or recurrent pancreatitis in children. Now coming to the genetic thing. In genetic we can have cationic trypsinogen gene, carboxypeptidase A1, chymotrypsin C gene, cystic fibrosis gene, trypsin inhibitor gene. Fine. Now coming to the infectious causes, there are a lot of infections which are associated with acute and recurrent pancreatitis. Let's look at the infections now. First one is Escherichiasis. Even Escherichiasis is associated with pancreatitis. COVID-19, Coxsackie B virus, Ecovirus, Enterovirus, Epstein-Barr virus, hepatitis A and B, herpes virus, influenza A and B, leptospirosis, malaria, measles, mumps, mycoplasma, rabies. Even rabies is causing acute pancreatitis, man. And rubella, Reye syndrome, that is varicella, and influenza B, septic shock, thyroid fever. There's something called thyroid fever. Now coming to the obstructive causes. Let's read the obstructive causes now. Starting with ampullary disease. Ascaris is given in both the infection and the obstructive causes. Biliary tract malformations, choledochal cyst, choledococele, cholelithiasis, microlithiasis and choledocholithiasis or stones or sludge. Duplication cyst, endoscopic retrograde cholangiopancreaticography complications, ERCP complication, pancreas divisum, pancreatic ductal abnormalities, post-operative sphincter of Oddi dysfunction and tumor. Now coming to the systemic diseases which can cause acute pancreatitis. Autoimmune pancreatitis, brain tumor, collagen vascular diseases, congenital partial lipodystrophy, Crohn's disease, diabetes mellitus, ketoacidosis can also cause acute pancreatitis, any head trauma, henoch-Schönlein purpura, hemochromatosis, hemolytic uremic syndrome, hyperlipidemias, hyperparathyroidism or hypercalcemia, Kawasaki disease, malnutrition, organic acidemia, peptic ulcer, periarteritis nodosa, renal failure, scorpion venom, systemic lupus erythematosus, transplantation of bone marrow, heart, liver, kidney, pancreas, and vasculitis. These were all the causes, systemic diseases causing the acute pancreatitis. And now the traumatic injury, any blunt injury, any burns, any child abuse, hypothermia, surgical trauma, and total body count. Total body cast. Now starting with the treatment of acute pancreatitis. The aims of medical management are to relieve the pain, often needing opioids, and restore the metabolic homeostasis. Analgesia should be given in adequate dose. Fluid electrolytes, and mainly we have to give analgesia. Fluid electrolyte and the mineral balance should be restored and maintained. Intravenous fluids, lactated ringer lactate solution is often required to correct the hypovolemia because of the poor fluid intake and the fluid losses secondary to the capillary leak from the systemic inflammatory response syndrome. So there is hypovolemia. Excess fluids should be avoided. Fluid therapy should be titrated to improve the vital signs and renal function. Nasogastric suction is useful in patients who are vomiting. Basically we have to give analgesia, we have to give fluid to correct the hypovolemia, and we have to avoid excess fluids also. Should be titrated to just improve the vital signs. Nasogastric suction is useful. Analgesia to relieve the pain, then fluids, IV fluids to improve this vitals, and nasogastric suction is third point that we can do. In patients who are vomiting, early refeeding decreases the complication rate and length of stay. Early refeeding. In patients with the pancreatitis who are not vomiting, and oral nutrition should not be stopped. Recovery is usually complete within 4 to 5 days. Fine. Let's see this. 1 second. In patients who are not vomiting, oral nutrition should not be stopped, and recovery is usually complete within 4 to 5 days. Prophylactic antibiotics are not recommended in inflammatory pancreatitis or with sterile necrosis, but broad spectrum antibiotics are used to treat the infected areas of the pancreatic necrosis. Elevated serum procalcitonin levels suggest infection. Procalcitonin levels, if elevated, can suggest infection. Gastric acid secretion is suppressed with the proton pump inhibitors. Enteral alimentation by the mouth, nasogastric tube or the nasojejunal tube within 2 to 3 days of the onset reduces the length of hospitalization. What we are reading is how to manage the acute pancreatitis. We gave analgesia, we gave IV fluids, we did nasogastric suction in patients who are vomiting. In patients, no, prophylactic antibiotics are usually not preferred. Fine. Inflammatory, because it is mainly an inflammatory condition in which there is, if there is necrosis, now it's a sterile necrosis. But a broad spectrum antibiotic, if being used, it is used to treat the infected areas of the pancreatic necrosis. Elevated serum procalcitonin levels suggest the infections. Fine, we have to look at the CRP to look for the infection. This is important, to look at the procalcitonin level to suggest any infection. Gastric acid secretion is suppressed with a proton pump inhibitors. Enteral alimentation by mouth or nasogastric tube or nasojejunal tube in severe cases for those intolerant of the oral or nasogastric feeding within 2 to 3 days of the onset reduces the length of hospitalization, complication rate and survival in the patients with a severe AP. So this enteral alimentation is basically enteral feeding. It's a method of providing nutrition directly into the GI tract when a person cannot eat enough by mouth, but their digestive system is still functional. Fine. So we can do that by mouth or nasogastric tube or nasojejunal tube within 2 to 3 days of onset. So we have to start with the 2 to 3 days of onset. Okay, this enteral alimentation of onset reduces the length of hospitalization. Complication rate is also reduced and survival in the patients with the severe AP. In children, surgical therapy of the non-traumatic AP is rarely required but may include drainage of necrotic material or abscess. So in children, surgical therapy of non-traumatic AP is rarely required. There is no history of trauma, So in case of acute pancreatitis, surgical therapy is rarely required, but may include drainage of necrotic material or abscess. But drainage may be required of necrotic material or abscess if present. Endotherapy for the common bile duct stones ductal strictures, and for drainage of the fluid collection is standard of care when indicated. Now coming to the prognosis, children with the mild AP do well and recover within 4 to 5 days. If there is mild AP, no, then the children recover within 4 to 5 days. When the pancreatitis is associated with trauma or systemic disease, the prognosis is typically related to the associated medical condition. Fine. Now moving ahead, let's keep this video this long only.